And we'll move on to the next session. The topic is endocrinology and tropics. The first topic is the endocrinology of envenomation by Dr. Charles. So before that, I would like to call upon the chairpersons to the stage, Dr. Sangumani, Dr. Palanisamy, Dr. P. Govindaraju sir on the stage. So the topic is the endocrinology of envenomation by the speaker, Dr. Charles.
He is from Colombo. He has completed in 2000 and postgraduate Institute of Medicine, University of the Colombo. And he has completed MRCP at 2012. And he is the member, President-elect, Sri Lanka College of the Endocrinologists also. So welcome to Tamil Nadu, sir. Probably this topic, because most of the paper of the snake bite is published from the South India and Colombo, Ceylon itself, because snake bite, especially Russell viper, is very common in the Colombo. And this is very relevant. This topic is very relevant because snake bite can lead to the lot of endocrinological changes, including the carbohydrate metabolism and mainly adrenergic metabolism. Even we can tell, even it can lead to the sympathetic storm, as we all know. So in acute situation, how can we handle that by endocrinological changes occurring in the snake bite? Over to Mr. Pillai.
Thank you, sir, for those kind words. First of all, let me thank the organizers of Trendo and especially Dr. Shaktivel for giving me this opportunity. My talk will mainly focus on Russell's viper causing hypopituitarism. So conflict of interest none declared. Right. So this is a story of a 49-year-old male from Rajangane who was bitten by a Russell's viper. He presented with bleeding manifestations and he was given Hefkin's polyvalent antivenom, and in 2 days they were able to discharge him. So this is the Rajangane Dam which provides water to these farmers. So this patient, he remained persistently unwell over the next 3 years. So his symptoms were generalized weakness, lethargy, sleepiness, and reduced libido. The examination was unremarkable except for a pale face. So on investigation, there was evidence of adrenal, thyroid, and gonadal axis deficiency. And the MRI pituitary was normal, and the other causes for hypopituitarism were excluded. So the diagnosis made by this astute physician, Dr. Henry Rajaratnam, and I was his trainee at that time. Later on, when I moved to Oxford for my overseas training, under the guidance of Professor John Voss and David Worrell, we reported this case, and in the meantime, we did a literature review of all the cases that were there in the English literature at that time. So there were 49 cases at that time. So the first case of snake bite causing hypopituitarism was reported in Brazil way back in 1958 by Dr. Wolf, and it belonged to Bothrops species. But the first case of Russell's viper causing hypopituitarism was reported in 1976 in Kerala, India by Epan and his team. From 1966 to 1974, they have had a database. They have looked at 600 patients, and out of these 600, they have come across 3 patients with hypopituitarism. So the outline of the rest of my presentation would be the epidemiology of Russell's viper envenomation, the pathogenesis, and the different presentations of hypopituitarism, that's acute, chronic, and posterior pituitary insufficiency, how we diagnose and manage this condition. So if you look at the epidemiology, Russell's viper is found across 10 countries in the Asian continent, but Russell's viper bite causing hypopituitarism has been described only in India, Sri Lanka, and Burma. West to the Bay of Bengal, you get Daboia russelli, and there's a difference in the species. It's Daboia siamensis that you get east to the Bay of Bengal. So if you look at the pathogenesis, Russell's viper causes local reaction, coagulopathy, renal dysfunction, and neuromuscular paralysis. So out of all these, it is coagulopathy that has a relation to hypopituitarism. So Russell's viper has a lot of procoagulant enzymes which can activate the clotting cascade, resulting in fibrin deposition and DIC. It also has a metalloproteinase called hemorrhagin, which can damage the vascular endothelium. And it also contains certain toxins which can alter platelet function. So the end result is thrombosis and spontaneous hemorrhage. So they reported the autopsy findings of 3 farmers who died following Russell's viper envenomation in Burma. I'm so sorry, the slides. All these patients who died immediately after postpartum hemorrhage, they had in situ thrombosis, whereas the one who survived and died at a later pregnancy, she had a shrunken pituitary gland full of fibrous tissue. So, as you all know, in pregnancy, placenta and the amniotic fluid contain substances which can promote thrombosis. So then some authors have tried to draw a parallel between Russell's viper bite and hypopituitarism and Sheehan syndrome. So do we have evidence to say that it's thrombosis which causes hypopituitarism in Russell's viper envenomation? At least in some it is true. So again, a wrong slide is what we are seeing here. I'm not too sure because I prepared the slides in an Apple computer. I'm displaying it in this one, I don't know. So then the other evidence is there was acute ischemic stroke due to bites caused by W. russelli, according to a study published by one of my colleagues, Dr. Indika Gavaramana. So he studied 500 victims of snake bite, and in 9 of those, he has showed that there was ischemic stroke rather than hemorrhagic stroke. So at least in some, there could be a similarity between Russell's viper bite and Sheehan syndrome. So is the pituitary more susceptible to the effects of Russell's viper envenomation? In a Burmese study, they have shown there is increased capillary permeability in the lungs and glomeruli following Russell's viper envenomation. So we might see a similar phenomenon in the pituitary as well, but so far we don't have any evidence to suggest it. And then in this interesting study, Harta et al., what he did was he isolated anterior pituitary cells from the rat, and he prepared a culture medium made out of Russell's viper venom, and he grew these anterior pituitary cells in that culture. So after a few hours, he noticed that the growth hormone TSH and ACTH levels went up. And then some of you might argue that these cells would have got necrosed, and whatever that was stored within the cells would have come into the culture medium. But they were clever enough to show that more than 90% of these cells were viable even after 4 hours. So therefore, pituitary may be more vulnerable to damage after Russell's viper bite. So again, you may remember Dr. Wolf, who reported the first case of Russell's viper snake bite causing hypopituitarism. So 65 years later, again he writes a letter to the editor of QJM following my article, and he says it is time to denominate hypopituitarism caused by snake bite, and he suggests that it is appropriate to name this condition after him. So I'm not here to discuss the merits and demerits of it, but what I want to show is even 65 years later, he is still active. So he must be a very lucky man. So how does acute hypopituitarism present? So in this study again from Burma, this gentleman, he studied 9 patients who were hospitalized with this constellation of symptoms, that is hypotension, impaired level of consciousness, and hypoglycemia. So out of these 9 patients who presented with these symptoms, 3 had evidence of hypopituitarism. And again, EPAN has written a case report of a 38-year-old male who required very large doses of cortisone during the acute envenoming, and they could not taper it off because when the cortisone was lowered to 1 tablet per day, the patient started feeling unwell. So the diagnosis is acute hypopituitarism, which this patient has developed. So this is another study from Burma where 20 patients were admitted to the renal unit with acute kidney injury following Russell's viper bite have been studied. So out of these 20, in 15 they measured the cortisol, and in 10 it was low. Then thyroid axis was deficient in 9, and there was hypogonadism in 12 out of 17 males and 1 out of 3 females. But interestingly, Professor Sam Kularatne from Sri Lanka, he looked at the complications of Brussels viper bite in 336 victims, and it is surprising to see endocrine complications or hypopituitarism has not been seen in any of these patients. So when I communicated with him also, he said he did not come across any symptoms suggestive of hypopituitarism in any of these patients. So maybe there is a regional variability as well between Burma and this part of the world. So now we look at chronic hypopituitarism. So how do we define chronic hypopituitarism in this context? So these patients, they recover from acute envenoming. At that time, they show no signs of hypopituitarism, but later on, they develop insidious symptoms of hypopituitarism. So again, Toonpi et al. Has done this study also. So he looked at 24 patients who survived Brussels viper bite. And then they were recruited into the study 2 weeks to 24 years following the bite. And then the pituitary functions were analyzed way back in 24. So this is in 1987. And this is one of those patients. So out of these 24 survivors, they classified them into two groups. That is, those who had clinical features of hypopituitarism and those who did not have clinical features of hypopituitarism. So if you look at the 7 patients with clinical features of hypopituitarism, almost all of them had at least one axis which was deficient. So all 7 had growth hormone deficiency, but quite a number had involvement of other axes as well. But on the other hand, the important thing is those who did not have clinical features also, 4 out of 17, they had subnormal response to insulin tolerance test. So that means that we should have a high degree of suspicion when it comes to these patients. So if you look at Burma, at least, there is a relatively high prevalence of hypopituitarism following Brussels viper bite. Again, Majid et al., they have reported this case series at a conference in Madurai in 1987, where they have reported 6 patients with chronic hypopituitarism following Brussels viper bite, and all were symptomatic at that time. But when they traced back to the acute stage, all had acute kidney injury and hypotension, and the time taken to diagnose hypopituitarism ranged from 2 months to 20 years. So the important point that they are making is all have had symptoms of hypopituitarism soon after recovery. So again, it might point to the fact that we are missing out on patients with hypopituitarism in our population. Because if you look at the symptoms of hypopituitarism, those are very insidious and non-specific. Weakness, lethargy, hoarseness of voice, swelling of the body, reduced body hair, loss of libido, erectile dysfunction, menstrual disturbance. So we might attribute it to so many other causes. So therefore, we should have a high degree of suspicion. This is another interesting case from Kerala, where your patient has gone with psychosis to a psychiatry unit, and they have made the diagnosis, I think with the help of endocrinologists, that it is secondary to empty cellular syndrome following Brussels viper bite. Moment they gave steroids to the patient, the psychosis disappeared. So posterior pituitary insufficiency, this is far less common than anterior pituitary involvement. There are only 4 reported cases in the literature, and all from India. And osmolalities were not measured in these cases, but still they responded to vasopressin. So that means it is probably cranial diabetes insipidus, which is consistent with posterior pituitary involvement following Brussels viper envenomation. So this is an interesting case. This patient was discharged 4 weeks after the viper bite. He developed features of hypopituitarism. It was confirmed biochemically. Then he was started on hydrocortisone. Moment he was started on hydrocortisone, he developed polyuria, and he responded to vasopressin. So when you have anterior and posterior pituitary insufficiency, the posterior pituitary insufficiency will be masked. So moment you start giving steroids, you will unmask posterior pituitary insufficiency. So are there any predictors to say these are the patients who will later on develop chronic hypopituitarism? So in this study, which was published in the Pituitary, again study from India, they have looked at 9 patients who developed hypopituitarism following viper envenomation, and compared that with 87 patients who did not develop hypopituitarism. And then they showed a statistically significant prevalence of hypotension, coagulopathy, severe envenomation, dialysis requirement, and CKD on follow-up in the population that developed hypopituitarism later on. So these may be the predictors. Again, a similar study from India. Here they compared 9 with hypopit with 27 who did not develop hypopit, and then to see the predictors for severe Russell's Viper envenomation, multi-organ dysfunction, bleeding, and need for transfusion. So if there is severe envenomation with renal involvement and severe bleeding manifestations, very likely these patients might have a high chance of developing hypopituitarism. So how do we diagnose hypopituitarism? That's not a strange thing for you all, but here my focus is all these patients are not going to come to a tertiary center where you find endocrinologists. As a result, these small hospitals may not have all the facilities to do endocrine tests. So therefore, if you suspect hypopituitarism, prior to giving steroids, in our article what we have recommended is you have to draw blood for free T4, cortisol, and testosterone or estradiol, and you can freeze the sample and keep. And later you start giving steroids, and at your convenience you try to get these tests done, and if they are found to be abnormal, then you can go ahead with the formal testing for hypopituitarism. So this is what is more practical to a rural setting. And how do we manage these patients? So in the acute phase, if you come across someone with impaired level of consciousness and hypotension, always think of hypopituitarism as a possibility. And when there is impaired level of consciousness, first thing is you have to exclude hypoglycemia. In that case, you have to give glucose. And later on, you have to give hydrocortisone. Again, you have to be mindful. You should not give intramuscular hydrocortisone because you might cause a hematoma in these patients with coagulopathy. So therefore, always you have to go for IV hydrocortisone. And you need to continue steroids until the patients improve. And when they have hypotension, the WHO CRO guideline for South India and Burma, it recommends steroids for all patients with hypotension in this region. So in conclusion, ladies and gentlemen, hypopituitarism is an important complication following Russell's Viper in countries like Burma, India, and Sri Lanka. It can lead to severe morbidity and mortality. Therefore, a high degree of suspicion is needed to diagnose hypopituitarism following Russell's Viper bite. So most of these bites occur in rural areas. Therefore, it may not be possible to confirm hypopituitarism with laboratory tests. Therefore, during acute envenomation, if you see patients with hypotension and hypoglycemia, you need to consider hypopituitarism because early initiation of steroids can certainly save lives. And if the patient develops polyuria, particularly after introduction of steroids, then it is worth investigating for diabetes insipidus. And chronic ill health in those who survive the acute episode again should make us think of hypopituitarism. Again, this is my last slide. In 2019, we are having a grand endocrine congress in Sri Lanka in association with the South Asian Federation of Endocrine Societies, where India is playing a major role, and the International Society of Endocrinology. So speakers like Will Young and John Voss will be there. So I would invite all of you to come to Sri Lanka in 2019. Thank you.
Thank you so much, sir, for such an interesting session.